Alrighty, good morning. Dr. Patino here at the Cosmetic Surgical Center of Cerrito. I hope everybody had a very blessed Easter. We had a great time. This is micro power assisted power because this is electricity. See, I turn it on. It's like turning on a toothbrush and it starts vibrating. And so this is incredible. But it's not just the tool, right? Because a lot of doctors have this power assist tool, right? But a lot of it is how you use it, right? So it's like basically having an electric toothbrush and using it properly means that you just go gently and let the tool do its work, right? So that you won't have any gum bleeding, right? But if you have the same tool, if you have the electric toothbrush and you treat it like an old toothbrush and you go jamming at it at full force and speed, there is going to be bleeding. There is going to be gum bleeding. And here is basically the same thing, right? Look at this output, Katie. Katie, you've been an anesthesia provider for how long?
3 years.
3 years, and you've done liposuction before, right? You've seen liposuction done. You did that, provided anesthesia for liposuction somewhere else, not here, right?
Yes, correct.
All right, so what do you think about these aspirates?
About the what?
The aspirate, the color of this that's coming out.
Yeah, it looks like fat to me.
It looks like fat to you,
Yeah,
right?
yeah.
Do you see any bleeding?
No bleeding at all.
No bleeding. Is that unusual?
It's very impressive.
Yeah, very impressive.
No
Yeah.
bleeding.
Yeah, exactly. And the whole case is gonna be like that. And so this is the fat that we are going to transfer into the patient's body. So completely bloodless and oil-less fat graft. And a lot of it depends on, many. Right, so a lot of things is we're coordinated too with anesthesia. So you're keeping the blood pressure within normal range, right?
Correct.
So that's important because I can do everything well, the patient can do everything well, but then the blood pressure is out of control, she's gonna bleed. There's no way we're gonna be able to do this. And so look how my strokes are very slow, very calculated. This is not only great because, look at the output, right? It's completely yellow fat. This is pay attention because this is what's gonna go into her buttocks. So stay tuned so you can see this very yellow aspirate going into her buttocks. Thank you. So a lot of it is what the surgeon does too, right? So the surgeon doesn't give any aspirin-like medications, no ibuprofen, no herbs, no vitamins of any kind, no enoxaparin, no heparin, no blood thinners of any kind. And with the traditional technique, the patient is in so much pain that the patient cannot walk because of the severe pain, and oftentimes they need to stay for a couple of weeks, maybe 10 days or a couple of weeks, in a facility with nurses to administer intravenous narcotics for pain control. Our patients don't need to do that, right? Why? Because they don't have significant pain because of the anesthesia that we use. And so that's why you see them on TikTok, basically walking 1 mile the first day, 2 miles the second day, 3 miles the third day. You see them walking out of surgery here. Early ambulation is the best way to prevent a blood clot. So we don't use enoxaparin, we don't use blood thinners, we don't use aspirin. So of course, with this technique, which is incredible, you can see this kind of aspect, right? And this has multiple advantages. So not only the patients don't have unnecessary blood loss, depending on how aggressive the surgeon is, and depending on the type of cannulas that they use and how much time do they have to do the case. These patients could bleed with a procedure like this from anywhere from 2 cups of blood to maybe even 5 liters of blood, which is extravagant. And they would need usually auto blood transfusion, meaning that they transfuse your own blood that you lose here. They have. Yeah, the blood that you lose here unnecessarily, I may add, because if they have this technique that I've been using since 2004, And you're welcome, if you're a surgeon, you're welcome to come and see this technique. Look at the blood up, look at the bloodless aspirate, oil-less aspirate, right?
Wow.
It's incredible. So no, we don't even have a machine to order transfuse. We don't need it. We've never done blood transfusion intraoperatively here ever, right? And we never had to reoperate anybody for bleeding either, right? Because look at this output again. It's incredible, right?
It is.
It is beautiful, gold, spotless, bloodless, oil-less aspirate. So in addition to much less risk of anemia, much less risk of this lack of energy from the anemia, the patients also, not only with the traditional technique are they in severe pain that they cannot walk, they are set up for a blood clot or thromboembolism. It's a blood clot that moves to maybe the lung, the heart, the lung, and can cause death, right? And we never had anybody die. We want to keep it that way. But the best way to prevent a blood clot is not enoxaparin, it's not heparin, it's not anticoagulants, it's early ambulation. Our patients walk, and as they walk, they prevent this most lethal complication, which is that of a blood clot. Thanks to God, we never had anybody die. We want to keep it that way. But not only are patients are very well protected in that sense, but they also have a lot of energy because they don't have anemia, they have a lot of energy, they walk, and they prevent these complications. We have thigh-high compression boots intraoperatively. With the traditional technique, most surgeons use only knee-high compression boots. And the reason why is because they've done studies and they have found out that even if you put the compression in the arm, it still works to prevent a blood clot. But our statistics are even better than those published. And so we never had anybody die from a blood clot. And so that's huge, right? And I never used blood thinners. I never used enoxaparin. I never used heparin during cosmetic surgery, right? That's something that we used to do, doing emergency open heart surgery. When we use open heart surgery, all the surgeons use the heart-lung machine to do open heart surgery, and I spent the first 14 years of my life dealing with bleeding and complications from other surgeons, right? Especially open heart surgery, right? And I decided now and then, you know what? There's got to be something that we can do and to prevent bleeding, It's incredible. So thanks to the Dr. Jeffrey Klein for inventing the tumescent anesthesia. I've been using it, but I've used a modified tumescent anesthesia, which is even better, way better. And I've been using it since 2004. I initially modified it for the breast, and I used it also for this. And it's a special recipe, that gives me this kind of results. The epinephrine, of course, that we put in here. That's something that Dr. Klein invented, to put epinephrine and lidocaine in the solution. But every surgeon knows that. That's not a secret. Every surgeon knows that. Yet not every surgeon can get this type of output, right? But so there's many things that go into it. Again, is also the technique. I think that's the most important part. My salt technique, the small, blunt cannulas, atraumatic cannulas. So there's many things that go into it. How to use tumescent, how much you tumescent, meaning, so it's not just a single thing, it's a multiple factors, multifactorial, right? And I'm giving her high definition here. We'll show you later how incredible this is. Thank you. So I'm ambidextrous. Most surgeons are ambidextrous. But I'm using my non-dominant hand. And even if you're not an ambidextrous surgeon, I would recommend that you use your non-dominant hand. Why? Because that's going to force you to go slow. And when you go slow, it's like driving a car. You're going to have much less risk of thrashing, right? So I compare surgeons to how fast you drive here in how fast you drive on the freeway. I drive 45 miles an hour, and this is the incredible output, much less risk of problems, right? Most surgeons with the traditional technique drive 75 miles an hour, and you can expect maybe 2 cups of blood. And there is some surgeons that are carb racers, and they do auto transfusions of the blood because they lose over a gallon. Those guys go 260 miles an hour, and so much more risk. And usually those doctors usually do, many cases in one day, right? So we just do, 1 or 2 cases maximum per day, right? We go slow, we use non-aggressive cannulas, and also, more importantly, for the patient, the risk of internal organ perforation is much less, because when we go slow, then you have full control of the cannula, you know exactly where you're going. And when there is incidence of internal organ perforation, something that has never happened to us, what happens is that the surgeon is probably tired, probably on the 10th day of the day, right? Maybe on a Friday night, maybe hungry, maybe sleepy. And and then what happens is much like going on the freeway at 260 miles an hour, like a Formula One car, Most of the time nothing happens, but you've seen those Formula Ones, It's incredible, When they win the race, everything is good, everybody applauds, the flags and everything, but you can also see them, crashing, right? And it's usually lethal, when a car crashes at such a speed, it's usually lethal. It's not a perfect analogy, but I think it's a pretty good one. Here in surgery is basically the same thing. If you go too fast, you may lose situational awareness and go into an area that you don't intend to go. The cannula just goes somewhere else, like you lose control of your vehicle. And so basically this is the same thing that can happen. You lose situational awareness, you lose control of the cannula goes to an unintended area and perforates an organ. Thanks to God, we never had that complication, and we want to keep it this way. So in addition to that, using your non-dominant hand is going to force the surgeon to use both hands, right? And split the work 50-50. So I do 50% of my work with the right hand, 50% with the left hand. As a result, my fatigue is less, right? And my risk also, for me, as a surgeon, a lot of these surgeons, they have occupational injuries in the form of tendinitis or, either to the elbow, the shoulder, or the wrist, And so you can limit your exposure doing it this way. But number one is the patient, right? Much less risk of organ perforation, much less risk of problems, right? Number two, the surgeon has also benefits. Silvita, go on the other side, and you can pinch, so you can see. But we're almost to the end, right? And look at the pinch step. Can you see Silvita pinching, right? And we're making the lines here for the. It's incredible, right? We have what, 0.5 centimeters on that? Yep. 0.5 centimeters. Let me show you here on this side, for example. See, look, let me see if I can pinch this, right? I'm gonna dry it up a little bit so I can pinch it, but it's like very, like 0.5 centimeters, right? And but look at the output on these. We're toward the end of the abdomen, right? We're gonna do the back later, but we get this incredible fat graft with zero blood and zero oil, and this is what's going to go into her buttocks. This very aspirate that we put in here, that's what's going to go into her buttocks. We don't use any commercially available systems to clean the fat, right? We collect it in normal saline, and that's all there is, And the reason why is because we don't want. Imagine you jumping into a pool that's full of water, right? That's what we do. We have the collecting system, and the fat drops into a cushion where the saline is. But if you don't do that with the traditional technique, the fat cell is going to jump into an empty pool and hit the hard surface, the hard floor, and break, you know. And so it's an analogy also, but it is very real. So there is many things that we do to protect the fat cell, right? And of course your fat graft retention, meaning that your butt is not going to deflate afterwards, right? It will deflate to a minimal, but normally with this approach, you know, we get maximum fat graft retention, right? But with the traditional approach, you lose maybe 25 up to 50% of the fat graft that you put, you lose, right? 50%. So what doctors do is they put more fat graft. They put more, expecting the drop, right? And they tell the patient, saying your fat is gonna die or whatever, right? But we don't do that. We have maximum fat graft retention. Our patients report almost 100% fat graft retention with this technique, and of course, it's because we're not aspirating fat and blood, right? It's only pure fat. Look at this. So it's only pure fat, and so if you aspirate fat and blood and then oil also, then of course you have to clean it. But even the best cleaning system doesn't clean the fat completely. You won't see this yellow aspirate. You won't see it when you go into the buttocks. You'll see maybe red or pink. You won't see this beautiful yellow, right? And like I said, we're toward the end of the procedure. We're giving her high definition. We'll show you the intraoperative photos, how beautiful she looks. But maintaining this incredible output is just incredible. And this is the fat graft that's going to go into her buttocks, unstained, without blood, and without oil. And you know what that means to the patient is much less risk of oil cysts. Of course, if you don't put any oil, there's not going to be an oil cyst because the body rejects that oil that doesn't belong in there, right? The same thing happens with the blood. The body rejects that blood that doesn't belong in there. It forms a callus, and so the body treats it like a foreign object, you know, like glass. So or a bullet fragment. The body forms a callus around it and encapsulates the blood, encapsulates the oil, right? And that's where you get the famous blowout fracture, which is a deformity on the buttock contour of the buttock. It's like a light bulb that sticks out of the buttock, right? And also the oil cyst, so it's a cyst of oil, right? That the body rejects, and it also, you can see it, right? Because the body pushes it out toward the surface, and then you see it, right? So those are complications that are much less likely when you have a fat graft that is obtained in an atraumatic fashion with the multiple advantages and tips that I gave you, and there's more. You know, I lecture yearly about these things, and I am the CEO of the World Association of Gluteal Surgeons, and you're gonna see how we do this also under auto. Wow, so the patient is on her side now. The buttocks, you can show this, I'm gonna cover the buttocks. So the buttocks are over here, and she's on her side. We're giving her a nice waist. But notice how my strokes are very, very calculated. I'm actually using my non-dominant hand. So we go slow, so much less risk of intra-abdominal injury. So we never had anybody have that complication, and thanks to God, and we want to keep it that way, right? But also much less risk to the surgeon of occupational injuries, including tendinitis of the elbow, wrist, and shoulder. If the surgeon uses 50% of the time the left hand and 50% of the time the right hand, then the surgeon is better off, but more importantly, the patient is better off, because is not being operated by a fatigue surgeon or a surgeon that's going at full speed, right? That's key here at the cosmetic surgical. So this is the waist. The buttocks are on this side over here. We're covering the buttocks. She's on her side. Look how beautiful she looks. Look at that, huh? And I'm gonna show you the pinch test. I'm gonna go this way first. You see, is pretty much at 0.5 centimeters. And we go this way, see, and 0.5 centimeters, see. And I'm gonna go this way. This is the waist area, 0.5 centimeters. You see it, Wendy?
Oh yeah.
0.5 centimeters. This is all over. Now this is part of the surgery, so this is what we do, and so that to confirm that everything is even. Even Steven, thank you. So the buttocks over here, she's on her side. Look at the beautiful waist. We're giving this smooth, beautiful waist. Let's see what the pinch test is. Can you see it from that side?
Yes.
0.5 centimeters, you guys. This is just incredible. Look at this. Beautiful, very regular. This is part of the surgery. This is what we do to make sure everything is regular and nice. And we can even do it this way, right? You can go from here, see, like that. Look at that. Over here, see? Beautiful, see? That's beautiful waist, you guys. Thank you. Wow, so we've done liposuction to the back. Look how nice she looks. You know, the definition of the paravertebral muscles and the midline, the paravertebral muscles here and the midline over here. When she stands up, this is what she's gonna look like. Very nice, yeah, very nice. All these very well defined, you know, like that, see? Thank you. Wow, so look at this ultrasound guided gluteal fat transfer. I'm looking at the patient. I'm looking at that beautiful fatless, oilless aspirated. It's incredible. And I'm looking at the ultrasound. So this has been done under ultrasound guidance according to the World Association of Gluteal Surgeons. We're putting the fat graft in a safe space, in the deep subcutaneous space where God put it. And this traditionally is a procedure that's done blindly, but has a high mortality of 1 in 3,000. When you do it under ultrasound and direct visualization, the mortality is near zero. So this is what we do. I am the CEO of the World Association of Gluteal Surgeons. I have over 35 countries of the very best surgeons in the world. We have 100. So we have 100. Now we're going to move to the other side and do another 100 on this side. It's very important to move and not to go from this side because there's more risk. Thank you. Right, so I move to this other side. So we do 100 on one buttock and 100 on the other buttock, all under ultrasound guidance to keep symmetry. And the most important thing is to do it under ultrasound guidance so you keep this procedure safe, because if you do it blindly, we'll show you on ultrasound how sometimes the space, the deep subcutaneous space, is so narrow. It may just be 1 centimeter sometimes. And the problem is that no matter how experienced the surgeon is doing it blindly, you can easily miss it and then go into the muscle and maybe injure the inferior or superior gluteal veins, which get 100, okay? So which get injured 80% and 20% of the time in cases like these, and there is a fatality rate is 100%. Pretty much everybody dies. So we never had anybody die. We want to keep it this way, but we do this under ultrasound guidance according to the World Association of Gluteal Surgeons guidelines. I'm going to go now from the midline. This is where these big vessels are that we're talking about, and we're going to do it under ultrasound guidance. We'll show you on the screen what we're doing. Thank you. Alrighty, Brooke. So let's point to the cannula first. So I'm wiggling the cannula right there. Okay, and then above that is the superficial gluteal fascia, that broken line right there, and way above that is the skin, right? And then below the cannula, there is a line below the cannula. That's the deep gluteal fascia right there, yeah. And what's below that? The striated muscle, right? That's where we don't want to go. So look how little this space is. How big is that space there? Like, is it 1.5 centimeter maybe, or 2? What do you think?
Yeah.
1.5 centimeter, right? So now look at the tip of my cannula. Okay, I'm gonna go ahead and redraw the cannula so you can see the tip of it. You see the tip of the cannula right there? Look at the tip of the cannula, Brooke, and point to it. This is it right there. There we go. And so we're gonna have some cloud of gray. cloud of gray. It looks great, but it's the fat graft. Okay, so 1, 2, 3, go. You see the fat graft coming out, and as it does, look at that. Wow, the deep subcutaneous paste gets filled in, and I'm gonna go in with the cannula and inject retrograde again, and see how now it's much bigger. Well, how big is it now? It's like 1 to 3 centimeters. It went from 1 to 3 centimeters, and now the muscle got pushed back. So it's incredible. This is how we do it. Thank you. What a gorgeous anatomy. Brooke, point to the skin, please. Very good. And the superficial gluteal fascia is right above my cannula. Right that's the superficial gluteal fascia. And then my cannula, I'm wiggling, look at the tip. And then the deep gluteal fascia is the next line below. There we go. And then the muscle is under it. Wow. Gorgeous. And now take a look and see. Take a look and see the tip of that cannula, and you're going to see this great cloud. That's the fat graft going in. 1, 2, 3, go. What's going to happen, Emily?
And the fat is going to enter in the space, and it's going to move the muscles down lower and create more space for the fat to go into.
Yeah, look at this. So now we went basically from 1 centimeter to 3 centimeters. So it's still a small area. So it's good to do it under ultrasound so you can avoid the muscle and you can avoid those huge blood vessels that have access to the direct systemic circulation. So they're very close to the vena cava and these anatomic locations. So that's why this could be dangerous if it's not done according to the World Association of Gluteal Surgeons guidelines under ultrasound guidance. Thank you.